exactly how we do the ER is like the low squat position, and they actually talked about like in Scotia and like I don't know what kind of data she said she'd read some studies, I didn't look at them myself, but that's like the most natural birthing position. You have gravity on your side,
Yes.
and it's low squat, and they like kind of hold the edge of the couch or something, and she said that
I think that definitely has that. I think that's kind of the idea behind the all fours. I think once a woman's already been in labor and you know the stability of somebody when they're squatting, you know, you need something there to hold on to, and this is kind of not exactly a controlled setting. I think if somebody wants to deliver in the squatting, in the controlled setting, that's probably fine. But in the emergency department, this isn't a labor and delivery ward. This isn't the home birth with a midwife where everything's set up and everybody loves each other. You're not out in the woods on a birthing block. And while it might work, because for the same reason that the gasket maneuver works, it's not something I'll probably do just because these are kind of tried and true methods, and the truth is that hopefully you'll never have to do it. But if you do, I'll probably do the gasket before I do the squatting just because this instability of the patient, at least the woman's on all fours, it's much more stable, and you can just kind of go there and kind of catch it. All right, so you did it. You're done. Right? The baby's out, the placenta comes out, you cut the cord, you know, the baby's crying, everything's going great. But what happens now is the mother's just bleeding, just continuous vaginal bleeding. What's going on here? Postpartum hemorrhage, right? So this is a very common cause of maternal morbidity and mortality. And what's the most common cause of postpartum hemorrhage? Uterine atony. Basically, the uterus, in a normal uterus right after delivery, it gets contracted, so kind of pretty much tamponades, it stops any more bleeding. But if the uterus doesn't contract, it's atonous, if that's a word, I just made it up. It's uterine atony. Basically, it's just going to continue bleeding and bleeding and bleeding. So you really need to know, which is why you want to massage the uterus probably at the baseline, but especially if there's a lot of bleeding, you're going to want to do, first of all, you're going to probably want to go in there and remove anything that might be left inside. So you're going to actually take your hand, you're going to kind of sweep inside, and then you're going to actually aggressively massage the uterus from both ends. So from vaginally and on top, aggressive massage. Hopefully you're hanging the Pitocin or getting the Pitocin ready, and that's going to help. I would probably give the 40 units in a liter at this point, or the 20 units in 500 at this point. And if it's still not working, there's other medications you can give. You can give Methergin, which is an ergot, which is the same reason why you give it to women who are, which they love to give it here to women with spontaneous abortions. But essentially it causes contraction of the uterus, and they're kind of the same thing that the Pitocin and the uterine massage should do. Hopefully at this point you can get an OB involved, because the last ditch is to really do an emergency hysterectomy, which hopefully you'll never have to see or do. All right, yeah.
The uterine massage and hanging the Pitocin, that's after the placenta's delivered?
After the placenta.
Okay.
Do not, I mean, you should probably wait until after the placenta is getting before it. You know, they'll probably say to hang the Pitocin right away. You have time. You know, women have been giving birth for millennia without Pitocin. But that being said, women have been dying for millennia in childbirth. So, you know, to say that normal childbirth has happened for a long time, which is why most of the time the baby's going to come out, everything's going to be fine, but you have to be prepared for the times where everything is not fine. Any questions on normal childbirth? Yeah.
I know a lot of times in these cases, OB comes down and they want the Pitocin IM as well, like give the Pitocin IM and then hang it.
You can give it IV or IM. It's safe to give IM. I mean, when you look at like kind of all the recommendations for delivery outside of the L&D ward, it's always just kind of IV in some sort of formulation. So Titinelli says 10 to 40 units in a liter. Someplace else it was 20 units and 500 mLs, but and that's why you want to establish the IV. If you don't have an IV and the woman has uterine atony, just give it IM. You can totally give it IM. Any more questions on normal delivery? Yeah.
I think the last time I ordered it in extramural, at downstate they only had IM, I think. We can order it only as IM, which we did.
It comes in a lot. I mean, you can always put that.
You can always mix it. Yeah.
Is the methyl ergotamine in the Pyxis, or where did you get that?
Yes.
Method, yeah, because we use that all the time actually, the Methergin, for just the first trimester of spontaneous ABs. But chances are you're not going to need that. This is kind of like next step, next step, next step. Hopefully the patient's up and healthy. Any more questions on normal delivery? There's all sorts of other badness that can happen revolving around the delivery, but I want to kind of move on. All right, so let's move on to our next case. So you just got the patient up, the patient's all upstairs, and you're like, all right, no more pregnant women for like at least the rest of the CCT shift, hopefully. Because you don't see a lot of pregnant women in the CCT, because most pregnant women are healthy, and except for the whole, parasite problem they have, they're fairly healthy people, which means that they don't get sick very often, which means that when they do get sick, it's very terrifying. And there's not a lot of experience, there's not a lot of research on it because it happens so rarely, and nobody's going to do a lot of studies on pregnant women. I don't know why, but such is the way. So let's say then you're working, you just got that patient up, and you're all excited and happy and celebratory, and then you get a notification, and they bring in this woman. She's 36 years old. She's got no known past medical history. She's had a completely normal pregnancy. She's at 38 weeks gestation, and she's coming in with dyspnea. These are her vital signs. Her blood pressure is, borderline. Her heart rate's 146, which you think is probably kind of fast. Her respiratory rate is 32. She's afebrile. She's setting 92% on a non-rebreather. So what are you guys thinking in terms of this patient? PE is definitely kind of up there. What else? Sorry? Cardiomyopathy, yeah. So pericardial cardiomyopathy, always something you want to think about in the very sick pregnant patient. Amniotic fluid embolism is always like kind of super scary, but much more rare. All right. So how do you approach the really sick pregnant patient? They're scary, right? And their physiology is a little bit different. So I think it's really important. I think in the last few weeks we've done a lot of pregnancy-related stuff. We've gone over a little bit of the physiology, but I do want to do a quick review of some of the important aspects of the physiological changes that happen towards the third trimester of pregnancy that might influence how you resuscitate patients. So, changes in pregnancy. First is respiratory. The diaphragm gets lifted up, so the abdominal contents are kind of moved up. And what that means is, and you have an increase in your, essentially, your tidal volume goes up, all right? Your increased minute ventilation, but you have a decreased functional residual capacity. And what that means overall is that your oxygen stores are much lower than the non-pregnant patient. And that's really important when you're trying to resuscitate a really sick patient and from an airway and breathing standpoint. Okay, so their oxygen stores are much lower. Their ability to ventilate is limited by their decreased lung volumes because of that increased diaphragm and their abdominal contents moving up. It's also really important in the setting of trauma because if you're going to put a chest tube normally over here in the pregnant patient, you're probably going to have to put that chest tube in at least 2 rib spaces higher. I'm not really going to go into trauma too much in the patient, so just important things to remember that the anatomy is a little bit different of the abdomen and the chest if you're going to do any procedures in the setting of trauma. All right. Cardiovascularly, cardiac output goes up by 50%, which is like huge if you think about it. I guess it's got to accommodate another being, and it does that by increasing both the heart rate and the stroke volume. And so it's important to realize is that a little bit of tachycardia is normal in a pregnant patient, but it should still be just kind of mild resting tachycardia. If the patient has a resting heart rate of 125, then you can't just be like, she's pregnant. It's important to realize also in the setting of trauma, if they're bleeding from somewhere or trauma like abruption of the placenta or previa, because of that increased stroke volume, they're going to bleed out a lot faster. Think about it. If somebody has a stroke volume that's 50% higher, that means that their blood's going to go out of their body 50% faster than somebody else who does not have that increased stroke volume. All right. And then supine hypotensive syndrome. And what that basically means is that there's a giant being inside their abdomen and it's pushing on the IVC. And what that means, decreased return to the heart, decreased cardiac output, and that could really impede your ability to resuscitate a really sick patient. That's uncomfortable in the normal pregnant woman. Just ask any pregnant woman who tries to sleep on her back. It doesn't last very long, which is why they usually sleep on the side. And those are kind of like important things when you're resuscitating a really sick patient. Also, their gastric contents, they have slower emptying because of the progesterone. So if they're going to aspirate, that's also kind of important if you're going to be doing an intubation and so on. All right. So you have a really sick patient, don't forget the basics. Your ABCs, or your CAB, depending on the scenario, you're gonna make sure you have an IV. If they're bleeding, you wanna make sure you have good IVs, and probably 2 of them. You're gonna put them on oxygen. Remember, their oxygen reserves are lower, so it's really important. And you're gonna get them on a monitor sooner, right away. All right? So, and then, you have that baby pushing on the IVC, decreasing return to the heart. So in order to mitigate that, you put them in kind of that left lateral decubitus position. Kind of shifts them over, puts the baby a little bit off the IVC, and allows better return. So if you have a really sick patient, that's one of the first things you should do for your pregnant patients. Kind of put them on the side, you're going to put them on the monitor, you're going to put your IV in, you're going to oxygenate. And if you can't get access, you want it to be above the diaphragm, right? Because of that cable pressure, putting in IO in the legs or a central line in the groin is probably not the best option in a pregnant patient. And even the crashing patient, you probably should not be putting in anything below the diaphragm. Go for the good peripheral IVs. If that's not feasible, I would probably, if you have to put an IO, I'd put it in the humerus. And if I had to put in a line, I would do probably a subclavian, because I probably wouldn't mess around with an IJ with an ultrasound. I'd probably just do either a supraclavicular or a subclavian. All right. So this patient, you're resuscitating, you're working her up, your big differential is PE, and you're kind of like deciding, should I CAT scan or not CAT scan? By the way, the answer probably is you should CAT scan if you're strongly suspicious of PE. If you're like, well, I'll do a VQ scan because it's less radiation, probably the VQ scan maybe a little bit more radiation than a CAT scan in terms of infant radiation exposure. So if you're thinking about VQ versus CAT scan, there's not a clear answer because VQ scan is probably a little bit more radiation, if certainly not less than this CAT scan, but it's the CAT scan has a lot of ionizing radiation to a woman's breast, which increases the chance of breast cancer later on, which is kind of why you might not. But I think if you really strongly suspect PE, then I would just do a CAT scan. But your patient, you're working her up for her PE when all of a sudden she becomes unresponsive, apneic, and pulseless. And you look on the monitor and she's in asystolic arrest. So kind of like the worst thing you could ever, like one of the worst things you can ever see in the emergency department. All right. So a lot of this kind of how to resuscitate the cardiac arrest pregnant patient is coming from here, which is the AHA guidelines, same people who do all the ACLS stuff. What they did was they actually published their first specific guidelines to the resuscitation of a pregnant patient in November of last year. So this is pretty much what the guidelines are based off of now. And this is kind of a detailed, if you want to read the whatever 77 pages of text, have fun. But a lot of it's going to come from there. And what you'll find is that for most pregnant patients, you're going to do the exact same thing. You're going to do high quality CPR, which is probably the most important thing we do for anybody in cardiac arrest. High quality CPR, you're going to address the airway. You're going to shock them as if you would shock anybody else if they were in VFib or VTAC. You would give the same medications, the same dosings of epinephrine or amio if they have refractory VFib or VTAC. It's all the same for the most part. There's some subtle differences. So how is it different? First of all, it's really important at the onset, especially if you don't know, is to estimate the gestational age, because that's going to really kind of be really important during your resuscitation. And really the thing to remember is the belly button. So the belly button is estimated to be about 20 weeks. So at anything kind of at or above the belly button, you're going to assume maybe around the 24-week mark, which is the viable mark, which is important if you're going to perform perimortem C-section. Because if you don't feel the fundal height at the umbilicus, or if it's below, you probably shouldn't be performing a C-section. It's also going to be very different in terms of how you treat the patient. You're probably not going to force the C-section in terms of maybe saving the baby if you already kind of realize that the mother is not salvageable. All right. In terms of viability, that's kind of a very loaded question, which I don't want to go into. If you look at a lot of the guidelines say viability is 24 to 26 weeks. I think that number is being pushed every single day all over the place. But basically the rule of thumb is umbilicus, and that's all you really need to remember. All right, so you're going to load the boat. This is super important. As soon as you get the notification on the phone, you're going to call OB. You're going to call the NICU, PEDS. You're going to call, if it's a trauma or you think there might be a trauma or you're heard of maybe the word surgery, you're going to get surgery down there, get anesthesia down there. This isn't the patient that you're going to cowboy up on. All right, this is the patient where you're going to load that boat. As many people as possible, you're going to get into that boat, and you're going to call them as soon as humanly possible. All right, and this has kind of come up a bunch of weeks in the last month. What position should you put the patient? So we discussed in the unstable pregnant patient, you're going to put her in the left lateral decubitus. If they're in cardiac arrest, put them supine. And that's pretty much what the guidelines say. This is straight out of the guidelines. The patient should be placed supine for the chest compressions. There's not like a ton of data saying either way. They did a study, and they basically found that patients in the lateral decubitus position, the pressure of the chest compressions drops by like 35% in the lateral position, which is huge, considering the fact that the most important thing we could possibly do for anybody in cardiac arrest is high quality CPR. So if you're going to put them in the left lateral decubitus position, if you're not doing high quality CPR, you probably shouldn't be doing it. You should be putting the patient supine, and in order to alleviate the caval pressure, is you should be doing manual lateral uterine displacement. Okay? And there's two different approaches. You can stand on one side, and with one hand, just push it over, probably to the left, or you can kind of grab the belly from the other side and pull it over. This should be happening throughout the entire resuscitation. That shouldn't stop until you've either done a perimortem C-section or you've called the code. All right, and that's really important that you're going to do this lateral uterine displacement or manual LUD. All right, is that clear? All right, and then if it comes to it, you're going to have to start thinking about it probably the second the patient crashes, or even before the patient crashes. If you're heading in that direction, you're going to be thinking about a perimortem C-section. Hopefully, you're not going to have to do one. Hopefully, you'll have OB. So let's talk about the perimortem C-section. When are you going to do it? And really, the operative number is 5 minutes. And that's not, you should start thinking about doing a C-section in 5 minutes. That's when you should be done with the C-section. Basically, the baby should be out within 5 minutes of the cardiac arrest. So if the patient arrests in front of you, automatically you're thinking perimortem C-section. And they recommend it should only take 1 minute to do a perimortem C-section. So they recommend at the 4-minute mark is when you should start your cutting of the perimortem C-section. Now, that's if the patient arrests in front of you. We've all seen patients who arrested not in front of us, and they're down for who knows how long. And in that scenario, you're probably well past the 5-minute mark. Chances are, if you're going to resuscitate, then you should probably not even wait the 5 minutes. As soon as the patient comes in, you evaluate the patient, they're in cardiac arrest, and their fundal height is above the umbilicus. I'll probably just go ahead with the perimortem C-section. All right? And then what's really important is the OB is going to come down, and they're going to say, all right, let's take the patient up to the OR, because they've never done a perimortem C-section. This isn't their work environment. The OB attending's never even been down to the emergency room, right? And they're not going to want to do the perimortem C-section in an environment that they're not used to. But the answer is no. Okay? So there's that recommendation, and then this is basically right from that article, and it basically says that the recommendations are do not move the patient. That perimortem C-section should be wherever the cardiac arrest happens, because moving the patient is just prolonging the C-section. You're not going to get high quality CPR in that movement process. So when the OB comes down and says we got to take the patient up to the OR, you're going to say no, you're going to do the C-section right here, right now. There's no rule as to how the C-section is done. But as long as the OB can get it out, like she said last, like I don't remember her name, like she said, as long as you can get it out in a minute, it doesn't matter what technique you do. If you're doing fan and steel, you're doing a transverse incision, a lateral, it doesn't matter. You can take it out from the back. As long as you're getting the baby out, that's really the key. All right, so you're 4 minutes in. Hopefully you've already started prepping for your perimortem C-section. And according to the AHA guidelines, the only thing you need is a scalpel. There's probably other things that might help you. I would say scalpel and at the minimum scissors, because ideally you probably want to do a lot of your cutting with scissors to minimize the damage you're going to do with the scalpel. And then there's all this stuff. This is also from the Tintinelli. You probably don't have a perimortem C-section tray. You'll probably end up just using a cardiac arrest tray or something and using all the equipment in there. Ideally, blunt scissors is probably ideal. You're going to have clamps ready for that cord. And so let's see. So what are you going to do? So classically it was taught basically xiphoid to pubis. You just cut all the way down. And after reading about it, it's whatever you're comfortable with. Chances are, if it was me, I'm probably just going to cut all the way because I'm not a surgeon and I'm not used to going into a uterus and looking at it. But if you feel comfortable, like you've seen a ton of C-sections on your rotations, or you like going into C-sections, if you want to do just kind of umbilicus to the pubis, as long as you can access the uterus and get the baby out in a minute, any way you do it is fine. Here's the other option. Try to go around the belly button rather than through it. If you don't, don't worry about it. It's fine. So basically, you're going to cut down all the way through the layers. You probably, what they recommend is cutting through the peritoneum with the scissors, right? And then you're going to make an anterior midline incision into the uterus. Try not to go laterally, because that's where the vessels are, and you don't want to cut those vessels. You'll probably, you'll see in the video, they'll make a nick at the top and then cut the rest of the way the uterus to avoid damaging the fetus with the scissors. And then you're going to basically deliver the fetus and hopefully, and then during this entire time, chest compressions has not stopped. There's somebody doing that C-section, and there's somebody else continuing to resuscitate that mother. All right, and you're going to deliver. Usually, somebody might help you push. You might want to put down a bladder blade to try to just use it for mostly for retraction rather than protecting the bladder. Any damage you do, if the patient survives, that can be fixed. And the idea here is to save the mother and possibly the infant. And when are you going to do this perimortem C-section? So first, you might want to do it to save the mother, because you're not going to get a good resuscitation with that infant in there. And that's really why you're doing it. Because if the mother dies, then the fetus is for sure going to die. But there's going to come a certain point where you know the mother's not going to survive, but maybe the fetus can survive, certainly in later pregnancy. So you're going to try to deliver that fetus to maybe have one of your 2 patients survive. So this is from WashU.